So I really wanted to have the opportunity for her to share, her perspective on infection control. That's obviously a big issue in healthcare facilities. For a variety of reasons, they're not doing as good a job as they could. And it's something that I think that we, will want to be pushing on. And I think, ultimately the goal of doing surveillance and tracking and reporting and all this stuff is to ensure that the right strategies are being implemented and that, the diff and everything is being reduced. So I think with that, Phenelle, I'll turn it over to you. And do you want to just introduce yourself a little bit and tell folks, your background? And she has a super cool accent, which I'm highly jealous of.
You too can have one if you go live somewhere else for a long time. Okay, well, this is really great, and I really appreciate Christian and Kit giving me the opportunity to do this, because I felt really bad about not being able to be at the summit. So I do a lot of presentations, both in person and remotely like this. So sometimes I have a set of slides, and then I get talking about, something else that's certainly related to the subject. So when Christian said now to introduce myself, I'm going to start off and give you my background and why I am part of the Peggy Foundation, and then I'll get into the slides. I may have to skip through a few of them, but everything that I'm going to do with you today is geared towards C. diff in the healthcare setting and how you can be an advocate for your family, your loved ones, yourselves, because I don't know if there's any better a person right now to share a story of being in the field, being an infection preventionist, doing all the right things that I have known for many, many years to help facilities prevent C. diff and other superbug infections, and then falling victim to it myself because I really didn't know how to take care of myself. So that sounds absolutely absurd given my background, but that's why I'm really looking forward to doing this, because I have been doing infection prevention for 35 years, and when I started in Baltimore, Maryland, we didn't have any such thing as C. diff. We had antibiotic-associated diarrhea, and we mainly got that from taking amoxil. So we've really, unfortunately, got into this messy situation, and I've really heavily concentrated on, for the past, since 2010, I was concentrating very heavily on multi-drug resistant organisms, including C. diff, so that when I came down with C. diff at the end of 2013, a lot of my colleagues actually couldn't believe it and they thought I was joking, because I was more involved with C. diff prevention at the time when I got sick myself. So before I move the slides along, I'll just give you a couple of minutes of what happened to me. I had to go in for elective surgery, and at the time they wanted a prophylaxis with antibiotics, including Flagyl, which, as you know, is the first line of defense with respect to infection for treatment purposes. So I elected actually not to take the Flagyl because I was concerned about some of the other side effects. But that is not, you can't take Flagyl ahead of time as a prophylaxis, like you do. Maybe probiotics may play a role, etc. So I know that by not taking the Flagyl, that doesn't create any problem for me developing C. diff about 6 or 7 days after I was supposed to take that. So when I was in surgery, they did what they're supposed to do for the type of surgery I had, and that was give me 1 gram of intravenous antibiotic, Ancef, that they were supposed to do. But then what they did afterwards was, and the surgeon said to me himself, when I said to him after I got sick with C. diff, why did you do that? Here are the guidelines from the surgical society that you belong to that says you shouldn't give an extra dose of antibiotics. He said to me, it was safer for me to do that than for you to possibly get an infection, because then it doesn't look good for me. So it was all about CYA. And what happened was, he did exactly what he wasn't supposed to do. And the reason I'm sharing this with you as advocates is because we have to advocate for ourselves, and we have to ask questions, and we have to make sure that we understand this whole process and what causes it and what we can do and how we can challenge healthcare workers, because they're not always right. So I didn't think to do that beforehand. I trusted my surgeon. I didn't expect him to put up an extra dose, but when they did hang the extra dose of Ancef, when I had my 24-hour stay or 23-hour stay in the hospital room, I was in so much pain. I looked at it and thought, you know, I should really rip that out because I could get C. diff, but I didn't. I decided I would be a patient. In addition to getting an extra dose of heavy-duty antibiotics, I weighed about 110 pounds then. I was small. I should never have been given 2 grams of Ancef. That was way too much. Was it the first dose that they should have given me that caused the C. diff? Was it the second dose? We'll never ever know, but the fact of the matter is that I was pretty much overdosed with intravenous antibiotics. Then, unbeknownst to me, and what my mother told me after I was taken back to the hospital with C. diff, was that she had noticed a brown isolation sign on the door of the patient next door to me. I had a private room. And my mom has been well trained by me, I guess, because she understands what isolation signs are all about. And the brown actually is indicative of C. diff. A lot of us in the hospital setting use the isolation sign that says contact precautions that's colored brown, because, not to be gross, but it's the color of feces. So she was correct. There was a C. diff patient in the room next door to me. As awful as I felt that night, and I don't make a good patient post-operatively, I was in a tremendous amount of discomfort. No, I really don't. I'm actually a good patient, but I don't make a good patient in terms of I have a horrible pain threshold, and I just am not somebody that should go under the knife. So I'm going to try very hard from now on never to have that happen again. But what I did happen to notice, and in fact my significant other was in the room there with me at the time, and noticed that the nurses were coming in and out without doing any type of hand hygiene. So I actually, at the time that I saw this, didn't say anything to them. There's mistake number 2. Who should know better than myself to not say anything to a bunch of nurses that are walking into the room and not using the alcohol sanitizer that is right there on the wall? Eventually, when the night supervisor came in, I said something to her. She gave me a horrible look, and she just looked and said, she actually didn't say anything. She shrugged her shoulders. And Eric at the time looked at me and said, that was rude. Okay, so there is my picture. So I get discharged on Friday night, on a Saturday morning, and by Tuesday midnight, my stomach is starting to feel really strange, and by 4 o'clock in the morning, I have a rip-roaring temperature, profuse diarrhea, and I'm now unable to, I can't do anything. I'm all alone in the house, so I called an ambulance, and I already knew what was wrong with me, and I made them take me back to that hospital, which was very far away from the local hospital here, and anyway, it was a nightmare. However, I survived. I was lucky in that I responded to oral vancomycin. My GI doctor didn't even try me on Flagyl. He said, I had abdominal surgery, so it was very, very difficult for me to have C. diff over and above abdominal surgery. It was unbelievably complicated. So it also delayed my healing very significantly. So he started me on oral vancomycin. Thank goodness I have a god of a GI doctor. He was absolutely incredible. And it took me about a month to recover, and I have been very fortunate since then. Okay, so that is my background, and the reason I've been verbose about it is because I know you are advocates, and I wasn't an advocate for myself. I made 3 big mistakes. I didn't question my doctor beforehand about what his process is for post-operative care, and what does he give for pre-op antibiotics. I also didn't say anything to the healthcare workers, and I really left my entire care up to in the hands of, pardon the pun, in the dirty hands of the healthcare workers. Okay, so the risk factors in the healthcare setting include, as we all know, and I'm not going to get much into the injudicious use of antimicrobials because I know that you've had a lot of information, and if you haven't, I'm certainly happy to do another webinar on this in the future, but I know that Christian et al. Has got a lot to do with this, has done a lot of this. But there's a lot of risk in the judicious use of antimicrobials, and there's also been, and that, by the way, means antimicrobials are antibiotics, antifungals, etc. There's also been talk about other medications, and I don't have time to get into that now, but the proton pump inhibitors, you know, the ones that are for reflux, seem to play a role as a risk factor as well. Continuing in the healthcare setting, we have to look at what we're going to do with patients that, or residents in a nursing home that come in with antibiotic-associated, you know, colitis, C. diff. There's often a lack of private rooms. There's lack of hand hygiene, not because we are lacking in sinks or alcohol sanitizer dispensers, but because people are not doing the hand hygiene the way that they're supposed to. Ineffective isolation, we don't always have cooperation. Environmental contamination, C. diff is a spore-producing organism. It changes from its vegetative state to its spore state, and spores are not penetrable. So we have to be really judicious about how we clean the environment in the healthcare setting. And then also lack of communications between facilities, between acute and long-term care. This is just a definition of an acute care hospital where you stay for a short amount of time unless you're in the ICU, and then you stay longer. And then, of course, the long-term acute care hospital is the transition between being in an ICU setting and a long time in a hospital to going into a rehab or long-term care. Long-term care includes nursing homes and skilled nursing facilities, and they're one and the same, and we use these terms interchangeably. And we do see a lot of C. diff in the long-term care setting. In fact, it's the #1 cause of diarrhea in the elderly. So we have a huge problem not only in acute care but in long-term care as well. We use prevention strategies that include bundles. We use bundles, and I'm going to go into some of this because I want you to see what we do in the hospital, what we should be doing in the hospital, what you should be looking out for if a loved one or yourself goes into the hospital. I don't want to use this webinar as a platform to scare any of you, but I want to be realistic. There are plenty of hospitals in the nation that are doing a really good job for prevention of transmission of infections. So, you know, not everything I'm presenting to you today is doom and gloom. We use bundles, we use the tiered approach, we use a basic and enhanced strategy approach, or something that's called core and supplemental. And these are all very clinical, so you don't have to be concerned about, somebody's giving feedback. There we go, that's better. So you don't have to get too carried away with worrying about what this is all about. I just want to give you some idea of what we do in the hospital. So the key to prevention of the spread of C. diff in the hospital or in any other clinical setting like nursing homes is to place all patients or residents with diarrhea on contact precautions until C. diff infection has been ruled out. But we also have to rule out other causes. Sometimes, especially in the elderly, laxatives cause diarrhea, new medications, change in a diet, tube feedings, and norovirus, which presents differently to C. diff. But if somebody's had antibiotics and then gets exposed to norovirus, it can present pretty much looking similarly with the diarrhea. I don't know if any of you know about the dog sniffing C. difficile, the dog that sniffs C. diff. Sorry, I've got to think how to say this. I just discovered that on Facebook, the Angus is a dog that originated in Toronto. Dogs have a unique ability. C. diff has a very, very, and I hope none of you are eating dinner right now, but C. diff has a very specific aroma to it. And nurses and healthcare providers can tell very quickly which patients have C. diff. We know what it smells like. Well, they have dogs that can actually smell the odor. It's not an aroma, it's an odor. Better get my semantics right here. And they now in Canada. So if you want to take a look at this, there is the Facebook page for these dog sniffing, these C. difficile sniffing dogs. Oh my God, what a mouthful! So it's really been It's interesting to hear presentations about how these dogs have this ability to smell C. diff. So early identification is important, and then placing patients or placing in the acute care facility, very definitely a single room. We are able to do that. We have to move patients around. It can be very challenging, but we need to get them in on their own because it's so highly infectious, and the environment is a huge source of transmission. If we're not able to do a single room, because sometimes we're at maximum capacity and we can't move patients around that quickly, we cohort. We put the same type of organism in a room, if a single room is not available, in a double room, and then we are able to take care of 2 C. diff patients if there are 2 in a hospital, 2 or more. Contact precautions include wearing gloves and gowns when entering a room, regardless of the reason for entry. That's the difference between universal precautions or standard precautions, where we're going to put on gowns and gloves anytime we're touching urine, feces, any type of drainage, anything that looks and feels wet and sticky and yucky. Gloves and gowns are removed appropriately when leaving the room. And we have very specific procedures of how to don, which means put on, and doff, which means take off, gowns and gloves. In the long-term care setting, in the nursing home setting, so if any of your family, relatives, loved ones have to go into a nursing home, friends, and you are aware that there may be some C. diff lurking or they're going to go into antibiotics, you need to know that it is a big challenge in the long-term care environment. So we prefer to put them in a private room, but remember that a lot of people in long-term care live in those rooms. That becomes their home. So it's difficult to take them out of that environment. So then we try and cohort them, or we place them with residents who are at low risk for acquiring CDI. So residents that are not on antibiotics, residents that are not taking proton pump inhibitors. And we try and be careful about who's going to use the commode versus who is going to use the regular bathroom, because you always put one of them on the commode, so you separate them during their bathroom needs. And we have ways now that we can use liners, disposable liners, and there's a whole protocol to how we take care of these patients. Hand hygiene, hand hygiene, hand hygiene. If there are only 2 ways that we can stop the spread of C. diff in the healthcare setting, it would be hand hygiene and cleaning of the environment. This is where you as advocates need to really speak up. I always have spoken up for any of my family members that have been in the hospital. I just felt too horrible to speak up for myself. I couldn't care at that point in time. We have to care. So performing hand hygiene before and after contact with the patient. Washing hands if visibly soiled, as alcohol will not penetrate protein material. Alcohol hand sanitizers actually do not penetrate the spore of the C. diff on the hands. However, it is shown that using alcohol has a better efficacy in preventing the transmission of C. diff than insisting on hand washing, because a lot of times people don't have the same ability to wash their hands as they do to use the alcohol. I am still a strong proponent of hand washing. I still say if I've got a C. diff patient, I'm going to make sure I don't contaminate the door handle. I don't go out and turn on the faucet in the main area without using a paper towel. But a lot of people say it's better to just use the alcohol sanitizer in the room till at least you can get out of the room, and unless you want to use the sink, but you've got to be careful that you don't contaminate the sink. So when we are taking care of patients with C. diff and we're changing sheets, linen, the gown, whatever we're doing, we have to be so careful once we take off our gloves that we make sure that we practice appropriate hand hygiene, because if we don't, we're going to end up with a patient next to them or a patient next door or down the hallway with the C. diff. This is enhanced. If we have an outbreak or we have an epidemic or we have more than a few patients, then we go straight to hand washing and we actually get rid of the alcohol sanitizers. We either remove them or we put a big sign up that says you can't use the alcohol sanitizer. So you look at every situation separately, and we base it on that. Contact precautions, we make sure we place signage visibly at the entrance to the room so that everybody knows they have to put on gowns and gloves as they enter the room. We make sure that, again, hand hygiene. We be mindful in the long-term care setting of restrictions for signage, because there's a whole another resident privacy right issue where you're not supposed to put anything up on the door except a stop sign that then alerts people to go to the nurse's station. We try and dedicate as much equipment as possible. When you're watching what's going on in and out of the room, make sure that people, when they're coming into the room with anything, are cleaning it when they come in and cleaning it when they take it out, or they dedicate a blood pressure cuff, a disposable stethoscope. We have an isolation cart outside or just inside the room. We need to make sure that we are mindful of equipment that can spread from room to room and patient to patient. And cleaning the equipment between patients or residents is very important. Again, I mentioned gowns and gloves. Gowns and gloves need to be worn throughout the duration of the healthcare worker's stay, and they need to be appropriately removed, and we do have nice signs as to how to take it off, how to roll the gloves, how to roll the gown inside the gloves, and then, of course, the hand hygiene. I've already been through this about the sharing of equipment, using dedicated equipment, and hand hygiene and gloves, etc. We have many different ways to put basic signage up on the doors. These are just some of the examples. You may see that. It doesn't mean that if you see these contact precaution signs on other people's doors that they have C. diff. We know which patients have C. diff. We also have to remember that there's a HIPAA violation, so that we can't very well put the word C. diff on the door of patients in a hospital setting. The one on the left is not a C. diff sign. It's orange, but that's just what the manufacturer of those signs makes. But there are certain brown signs that we will use, but not every hospital that uses a brown sign is indicating that there's C. diff. So it's important for you to know what's going on in your room or your loved one's room, not so much on the outside, because you want to advocate for your person there. We enhance communication by placing placing signs on the doors, and we also monitor for compliance. So we have people that are watching for compliance and reporting it back to the key staff people. So there are some different signs to take a look at, and not something that I want to spend too much time on. Our cleaning is vitally important. Daily cleaning actually is okay with an EPA-approved germicide, again in a non-hyper-endemic setting, when we don't have an outbreak in the hospital, when there's just the odd C. diff patient that is presenting. We do more frequent high-touch surface cleaning. We monitor cleaning compliance, especially for the appropriate germicide contact time. It has to stay wet for a certain amount of time, and if equipment is shared, we are cleaning between patients with that germicide. Now, on an enhanced level, and what I am seeing and have been for many, many years, so while I am giving you the CDC guidelines, most of us, no matter whether it's a basic method or an enhanced method. Now, we'll use the enhanced method if we have an outbreak of more than 2 or 3 patients. Most of us are using bleach because bleach does kill the spores, and bleach definitely prevents, if it's used appropriately, properly, left for the required amount of time on the surface in the environment, will kill the C. diff and prevent the spread that way. So what we do have to do, though, is we have to be very careful with bleach. We have to be careful because it's not always safe for the equipment. You can't really use it on blood pressure cuffs or anything that's fabric. And we have to be careful that the employees don't get overexposed to the sodium hypochlorite. So it's not a very safe a product to use, but nowadays we have bleach wipes, and they're much safer because we don't have to reconstitute the household bleach. So I am a big advocate of bleach as long as we don't use it for too long, and I still prefer it over the basic strategies. But again, we haven't seen an increase in the spread of C. diff from irregular household detergents in the hospital setting. Some additional prevention strategies: patient-resident transportation. We have to be very careful when we're transporting them from place to place, whether it be from outside inside the hospital to outside to another facility, or whether we take them into radiology or to physical therapy, if they can go there. We tend to try and keep them in their rooms when they're having active diarrhea. If we can't do that, then we try and contain it in adult diapers, and sometimes they have to have other care come to them, the other services come to them, like physical therapy, occupational therapy. We really need to communicate with everybody. We need to communicate with patients and families. We need to communicate with other healthcare workers. This is a serious disease or illness that can spread very quickly, and we need to make sure we keep the channels of communication open. Very important in the hospital setting in particular, we have laws that require us to do patient and family education for C. diff. So whether we give you brochures, whether we pull you aside and explain what your family member or yourself, what you have, we are required to do education, and we are also required to advise you of what we should be doing and what you should be looking out for. And then we try our best, and this is one of the toughest for us, is physician education about antimicrobial usage. So this doesn't only apply to acute care and long-term care settings. We're seeing a tremendous amount of C. diff coming from outpatient facilities, dental offices, clinics, multi-specialty centers, and private practice doctors. Why? Because of the misuse or the overuse of antibiotics. Antibiotics play a special role in healthcare. Many people would die without antibiotics, but we have to learn how to use them and what to use in order to stop this epidemic of C. diff. The last couple of slides include multidisciplinary teamwork. We really try hard in the hospital setting to work as a team. We're a group of healthcare workers who are all experts in different areas, and we unite for the purpose of planning and implementing best practices so that we can enhance the safety and well-being of our patients, which includes me and you and everybody else. So we really do. We work hard. We've come a long way. We have a long way to go with antimicrobial stewardship, but in terms of these practices, every year we do better. We really do. As long as we engage everybody, including nursing, the medical personnel, administration, the lab, housekeeping or environmental services, and the pharmacy. We really have these teams of people that concentrate just on multi-drug resistant organisms. So then the last thing that I want to mention to you, and then I'm happy to take questions, and I know I'm moving quickly, but we've only had a certain amount of time, and I can speak for 8 hours at a time on something like this. So what we like to do is, and what we're doing more and more of now that we never did before, was really engaging patients and families overall in your care. Education, sharing information, listening to patients. Listen to patients. That's always what I say to the nurses that I train. Don't ignore what a patient is trying to tell you. If a patient is telling you something about him or herself, he knows or she knows what he and she is talking about. Empathize. Please empathize. All of us as advocates have either had loved ones or have had this ourselves. We really need to empathize with those that have it. And for those that are sick, because it doesn't matter what we're sick with, and as healthcare workers, we really need to have empathy. And as healthcare workers, we need to guide people through knowledge and experience. I can only guide you through the knowledge that I've gained and through the experience that I've actually had myself. Providing resources is key. So when the Peggy Foundation does what you do, Christian, and everybody else that belongs, it is incredible to me to see what you can provide for people that have had, are experiencing this awful illness. That's just contact information if anybody has any questions, etc. That's what I use. This was part of another program, so it's not really relevant with the website, etc. But I would be happy to address any questions that you have. If you've muted your lines, if you want to unmute, and we can take some questions. If they are, if not, then this was a wonderful opportunity to do a very quick presentation for you.
Phenelle, it's Christian. I'll get the ball rolling. In terms of questions, with the gowning and with gloving for hand hygiene, I mean, this is something we've talked to the CDC about, and their sense is that gloving, removing soiled gloves, putting on fresh gloves, and the hand sanitizer was effective. Can you just clarify that for folks? Is that also part of it? Is that having them change gloves in addition to using the sanitizer is important?
Yes, absolutely. So and excellent question, Christian. Any time that, and I'll give you a good example of where it can break down as well. So when we are working in the room with the patient, we need to be wearing gloves at all times, because even although we may not be touching stool, diarrhea, we are touching the environment, and that is where a lot of the spores reside. So while we're working with the patient, we're using the same gloves. But if we are working with the patient and we're using and we're changing linen because the patient's had a bowel movement, where obviously the heaviest concentration of the C. diff spores resides in the stool, then as soon as we have put the linen into a bag, which will be in the room, which will then be taken out to the laundry room, or the soiled utility room, we have to take our gloves off before we exit, and I'll talk about gloves in the room that we change as well. Before we exit, so we put the soiled linen into a bag, and then we take our gloves, where the bag is already open, it's usually in a stand. We drop the linen in, we take off our soiled gloves, sanitize our hands, because it doesn't matter what we're going to do next. It's like when you get in a car, you put on a seatbelt. You don't even think about it. It becomes so routine. So we really need to sanitize our hands, because the sanitizer should be in the room. If we feel we can go and wash our hands in the room, as long as we're not going to contaminate anything, then we go and wash our hands and then put on a clean pair of gloves to then take that external bag of linen out of the room. But we don't ever want to walk out of a room with gloves that are soiled from the patient's environment. If we are doing something in the room of the patient, so we're doing something and then the patient needs to be changed, so again we've contaminated the gloves. We then will remove the gloves after we have cleaned the patient up, got the patient all dressed nicely, clean linen, and then we decide that we have to change the IV, or we have to do something else in the room with the patient, take vital signs. Then we need to think about taking the gloves off, discarding them, sanitizing or washing hands, putting on a clean pair of gloves. Those gloves are readily available in the room. They are usually in holders on the wall. They may be on a table, on a nightstand. There are tons of gloves available. We put on a clean pair of gloves. Once we leave the room, once the gloves are off, we never go out of the room with dirty gloves. Once the gloves are off, the hands are sanitized. Before we come back into the room, before we put gloves on, the hands are sanitized. Does that answer your question?
Yeah, absolutely. Do other folks have questions for Phenelle?
Hi, Christian and Phenelle. My name is Terry Hewitt. I am also an infection preventionist. And Phenelle, I just want to thank you. Great information. And for those who are not as familiar as you and I, hopefully it will be helpful and we'll get some take-home pieces out of it. So thank you.
Oh, okay, thank you. And feel free, Terry, if there was anything that, I said, I'm glad there's another infection preventionist on the line, because infection prevention is very interesting. There are a lot of gray areas. There's a lot of subjectivity. It's subjective. It's opinion based on what we learn and what we read. And if you put 10 infection preventionists in one room, you will get 7 or 8 different opinions, because we're all looking at the same thing, but we're interpreting it differently. So if there's anything that you feel that you could elaborate on, or that I may have said that you don't necessarily agree with, please go ahead and say so.
I will. I think you did great. And I agree with you in terms of the infection preventionists having a little different take. And a lot of our our knowledge and education, too, is based on experiences that we've had.
Absolutely.
So I thought you did great, and it was great information.
Thank you. Yeah, and there's a lot. I mean, there's a lot more to it, but I think what for tonight's purposes, really stressing being a patient advocate is very important. Terry, were you here from the beginning?
Yes, but I've not been able to go to any of the in-person meetings yet.
Oh yeah, no, I'm sorry. I meant the webinar. Did you join us in the beginning?
Yes.
Okay, great.
Yes,
so you were there from the beginning. Okay, so I think that, the point that I try to make was that I will never, ever not advocate for myself again. So anytime I can share, and you as an infection preventionist can share how important it is that we speak up, and that we speak up for our loved ones and ourselves, especially in today's day and age with all the yuckies that we have to deal with, the better off we all are. So I thank you. Thank you, Terry. That was very kind of you. And anybody else want to say anything? Any questions?
Yes, Phenelle, this Trish Cooley. And hi, I have one question, and that is with the need to mask and gown and glove up, is there any evidence to show that it's also necessary to put on booties when you're entering or exiting a room with a patient that has C. diff, since spores can remain on surfaces or get themselves on surfaces?
Excellent question. So I noticed that you used the word mask. So contact precautions, unless there is a specific reason. So, for example, when there's norovirus, which is the the stomach flu, as we term it in the lay industry, then we would wear masks, because when a patient vomits, there's microscopic aerosolization, and it's better for us to put on a mask. But in the case of C. diff, we don't wear masks because there has been some talk about, and there have been some studies done that have said that, particularly when you flush the toilets or the hopper, or you pour anything down the hopper, etc., that there could potentially be aerosolization of spores. However, I will say, and Terry, if you want to weigh in on this, if you know anything differently, we haven't really had any strong evidence to suggest that we should wear masks in the room. So we try not, for various reasons, we try not to over isolate, because that results in a lot of fear, and so we don't wear masks for C. diff ordinarily, but in terms of the booties, it's very interesting that you bring this up. Contact precautions, according to the CDC, does not include wearing booties, because there hasn't been much emphasis placed on the floors. Now, very recently, there have been a couple of studies that have come out that have actually stated that hospital and nursing home healthcare facility floors carry a lot more organisms that could potentially result in issues for patients. This is all very new. I must be honest with you, I've taken a cursory look at it. I think for now it is not suggested. There isn't any evidence right now to suggest that for C. diff we need to wear booties, and the reason is because that is not a method yet that we can attribute to transmission from person to person. So we've never really seen a case where we can say the only thing that we could think of that caused the transmission in a hospital or nursing home setting was the floor versus hands that are not cleaned or sanitized and the environment that is inappropriately cleaned. We really don't advocate right now for booties. I think that at this point in time is overkill, but we're always learning something different. So certainly, if that becomes a CDC, guide suggestion, we would take that to heart. So no, not at this point in time.
Okay, thank you.
Sure.
Can I just chime in on that, Phenelle? This is Terry.
Yes, sure.
What Phenelle said was correct, but I think the other piece to share is that if you see somebody with booties on, it's part of standard precautions. And so if there's a patient who is incontinent a lot on the floor and the staff feel that they may come into contact with diarrhea because the patient isn't able to make it to the commode or the stool, then that's when they should absolutely wear booties.
Yes, as long as
sense.
Right, as long as they're available. And absolutely, the other thing as well is that, you know, we have to think about, so the booties is, and thanks, Terry, you're correct. They're not often, and I may be wrong, I don't know if you work in the hospital setting, but maybe they may now be providing booties, but part of the isolation cart has not been.
They're not.
They're not yet, yeah, but you've got a good point. Anytime you feel like you need extra protection, while we don't want to alarm anybody, if you feel that that is something that you need to wear, then you can ask for booties. They may have to go to the OR to get the booties, but yeah. But what I think the problem with the flooring right now, these articles that have just come out, is that people drop things on the floor and pick them up, and then where is it going after that? So it's more contaminating, not so much our shoes, but contaminating items that fall on the floor and get picked up and get, you know, become contaminated by multi-drug resistant organisms, and they may actually be carried out of the room and then potentially contaminate other or transmit and contaminate other people or the environment. Good question.
Does anyone else have a question?
I do. This is Jacqueline or Jackie.
Okay.
Hey, I have a question that kind of contains to it. Phenelle, you being in the medical field and now in infection control, my mom's in a nursing home. I visit her 2 to 3 times a week. Up until I had C. diff, I have always been her advocate, but not that aware of, you know, infection control or how things should be done. Since having C. diff and also watching a lot of information on hand hygiene and infection control, I see a lot of things that aren't being done, like what you have stated. You know, this is like raising red flags. And they don't have places to wash their hands unless they use the actual resident's bathroom.
Yeah.
And you stated that they shouldn't be doing that because it could be contaminated, or they could contaminate it more, I guess would be. And there's 2 residents usually, in my mom's case, has a roommate, and most of them do. But I want to say something. I'm kind of, when they see me, they're coming, they're like, oh, what does she have to say now? And that was before, but now I see a lot of things that are happening that are actually not happening. So how do you think it would be for the best way to approach that?
Okay, so I just want to clarify something. When I was talking about using the residence or the patient's bathroom, it's perfectly okay to use it as long as people that are using the bathroom understand how to use the faucets and how to not. So the healthcare workers that are using the patient's bathroom, if that is because they want to wash their hands and there's no sink right out, right at the door, they can use that, but they have to be really careful that they don't contaminate coming straight from the patient. I mean, it's very easy to contaminate bathrooms, and that's why we try and clean a few times a day, and we get, so I just want to make sure that I don't put people on the wrong track. It's still a good idea to, as I said, hand washing is to me is still the best way to rid, as long as they wash hands properly as well, but the alcohol sanitizer can be used. In terms of what you are seeing, the nursing homes, I've done a lot of work in the infection control in nursing homes. In fact, I started my consulting business in long-term care. So, and I've also done a lot with the state of Pennsylvania with mandatory reporting for healthcare associated infections in long-term care. So I know exactly what you're referring to. Right. And even when I go in there and do consults and I see things that aren't being done properly, I get a lot of pushback. But at the same time, nursing homes are way more regulated than hospitals are. They are regulated up the wazoo. And if a nursing home just steps out of line and the regulatory bodies get a hold of that information, they can be in deep trouble. So my suggestion is, if you're seeing things that are not getting done then you can say, you should speak up and say, I just want to make you aware. I've had C. diff. I belong to a C. diff foundation. We have infection preventionists that are part of this foundation. They provide us with a lot of education. And I just attended a webinar on C. diff prevention of transmission in the healthcare setting, and this is what I was told. I'm not seeing that happening here. Can you please explain to me, why it's not happening? Is there a reason for it? So you need to make them aware that you are aware of what isn't being done and that you are concerned, because when you raise that red flag to them, they are concerned that you may take that further, because technically you could report them to the Department of Health.
Well, that's one of the reasons I asked about the residents' bathrooms, because I never see anybody washing their hands.
Yeah.
They go out and they use the hand sanitizers. I don't see a lot of people doing that, but I'm sure they are. But they'll remove the soil bedding from my, let's say, roommates, and they throw it on the floor.
Mm.
And you said, they should have, and I know what you're talking regarding the biohazard,
yeah, the bins and stuff. Yeah, no, they shouldn't be
that in. And then they move on and put the clean stuff on, or they'll pull. One time they were pulling my mom's bed sheets back, and I said, no, I'll do that. And I just thought, and this has all become very apparent to me since I went to the summit, and subsequently I have been watching tons of videos and collecting them on my YouTube channel for anybody to view. And so through all of that, I've learned so much, and now it's kind of, whether I'm in the dining room there, or even when I was in my dentist's office.
Oh, yeah. Mm-hmm.
Yeah, her assistant came in and took out the sterilized packs with no gloves on, and laid them out for the dentist. Then for her, my dentist came in, she washed her hands in the sink, put her gloves on, and I told her before she touched them, I said, those aren't sterile anymore because somebody used their hands on them.
That's the best way. That's the only way that I can, Jackie, there's only one message that I can get across repeatedly, and that is speak up. Speak up. You don't have to be obnoxious. You don't have to, you just have to I think letting the healthcare professionals know that you are an informed consumer is extremely powerful. It is very powerful. I really have to say that letting them know you are informed, and whatever shape that takes, whatever way you want to do it, about why you're so informed, go ahead and do. But just speak up, whether it's the dentist's office, whether it's a doctor's office, an outpatient surgery center, a hospital, or a nursing home. Unfortunately, nursing homes still are notorious for not giving good care. Some of them are brilliant at it, and some of them are just really plain lousy.
Yeah, that's why I go to see my mom 2 to 3 times a week.
Absolutely.
I spend a lot of time there.
And it's okay to say, when somebody comes into the room and there is alcohol sanitizer available, and they come in to do something with your mom, it's okay to say, excuse me, but could you please sanitize your hands? And then when they say to you, we just did that outside, then say to them, I'm sure you did. I trust you, but I am really nervous. So if you could just do it again so that I am aware you're doing it. Because when the Joint Commission comes into the hospital, or when the Department of Health comes in to the nursing homes, if what we don't see, we consider hasn't been done. As surveyors, we don't care. If we don't see it, it hasn't been done.
Right, and I see so much. It's
I'm sure you do.
That I've seen, because I sit in the dining room and I see them walk in, and they haven't. I don't see them using the hand sanitizer as they walk in, because it's right on the inside of the door.
Yeah, that's the problem.
And they go straight to the food, and then they start peeling everything and setting glasses down. And I just want to stand up and go, stop.
Yeah.
So I will. I think that.
Yep. Absolutely. Just keep on advocating. That should be the slogan. But thank you. That was very informative, and I appreciate you sharing with us.
Thank you very much.
All right. Well, I think if there are no other questions, I think we'll let everyone get back to the rest of their evening. Our dog is wondering why I'm not snuggling on the couch with her yet. So thank you so much, Phenelle, for taking the time and doing this, and we really appreciate it. I'm so glad that people had the chance to join us, and I know that we're going to be hearing great things from these advocates as they go forth with this new information.
Good. Thank you so much. Thanks for the opportunity. Have a good night, everybody.
Bye-bye.
All right. Thanks, everybody.
Thank you.
Bye.